Tonight on Diabetes Chat, we welcome Dr. Banshi Saboo from India. He is distinguished healthcare leader with a commitment to advancing diabetes care with a proven track record of leadership and innovation. He has spearheaded impactful initiatives recognized both nationally and internationally. Notably, he launched a groundbreaking diabetes-free India project. And tonight, we welcome Dr. Banshi Saboo to Diabetes Chat. We are going to get to know him a little bit, his passions, his inspirations for a better future of diabetes care. We'll be talking about type 1 diabetes, type 2 diabetes, and other types of diabetes. We'll be talking about global access to diabetes care, management, treatment, and technology. We'll be talking about education, diabetes stigma, to Banshi tonight, which will be really, really fascinating. Thank you and welcome, Banshi. Welcome, Dr. Banshi Saboo, to Diabetes Chat today. Thank you for being our guest speaker. And to start this evening, could you introduce yourself, your connection, your sort of career background? What is your role and why did you want to sort of pursue that career?
So I am Dr. Banshi Saboo. I am currently practicing as a diabetologist. Since last 28 years, I am practicing in city of Ahmedabad, which is western part of India. It is seventh largest city of our country and it is in Gujarat state. I am practicing as a diabetes specialist after my fellowship and my post-graduation in medicine. Currently, I am chair of International Diabetic Federation of Southeast Asia region. International Diabetic Federation is a federation of organization which are from the different countries. Organizations are the member of it, and several regions are there. So one of the region is Southeast Asia. So I'm chairing that. I'm also in the global board of EASD, which is European Association of Study of Diabetes. I'm heading Diabetes India, which is our National Society of Diabetes India, as a secretary. And I'm also very actively involved with many international organizations who are working with Diabetes India, which includes SPAT, which have like CDIC and LFSC projects where I'm the nodal hub for them. I'm also involved with organization like hypoglycemia study group or some obesity, which is like Asia Oceania Society of Obesity. So my practice includes from type 1 to type 2. It's a private setup clinic where we see patients for type 1 and type 2. I have associated doctors, students. We have dedicated type 1 clinic. We run once in a week a education program for type 1 diabetes patients. And we also see the patients of type 2, obesity, metabolic syndromes, all other aspects of diabetes which is taken care, including technology, because in India, technology usage is not very high. But as I am in private setup, not in public hospital, so we see patients who are affording and we offer them even the latest technology too, like insulin pump, continuous glucose monitoring. So this is all about me. But my interest for diabetes is that before 25 or 28 years, the incidence was not very high, but still it was looking like that we will have more number of people with diabetes. We were running in our postgraduate department a dedicated diabetes clinic where we used to see a lot of patients with more than 300 diabetic patients used to come. But at that time, type 1 diabetes care, which I used to see in a public hospital, was really poor. A lot of patients were getting complications. They were not getting insulin supply properly, and many of them were even dying because of even diabetic ketoacidosis on acute complication. That was one of the my reason why I chose the diabetes as my profession. After my post graduation, I have done my fellowship, and my interest for type 1 was that being a diabetologist, I should do something which will really change the picture of this type 1 in India who are not able to get the insulin or not able to get education properly, and they are not actually getting good treatment, and they are dying either in their young age or before, uh, even some of them even before the diagnosis too, or even first time in diabetic ketoacidosis. So that was one reason. And over a period of time, what I have seen in last 25 years, the incidence of type 2 diabetes in our country increased so much. Increase in obesity is a challenge, and we started working with a lot of organization at national and international organization. So that had helped us to grow in the field of diabetes, and I could do more work at national level in because of Diabetes India, by educating more doctors, my colleagues, primary care physicians. We are running a primary care diabetes in India that is a part of a Diabetes India group. We also have interest group like D Genius, which is a young diabetologist of India. They are also the part of it. We have tried to include all those foundations who are working in field of type 1 diabetes, whether it's a parent association or patient associations. So we have also collaborated with them. We collaborated with governments, the state government, the national government, and tried to influence them, tried to do some advocacy. First advocacy which we were doing, that no child should die of lack of insulin. That was the first, internationally also we know that. So we tried that each and every part of the country, wherever at least public hospital, at least tertiary care hospital, where Department of Medicine and Department of Pediatrician is there, at least insulin supply is there. But
Yeah.
definitely still a lot of things have to be done, and we are educating the people.
I
And
think I think, like you say, that there are still a lot of things to be done. But in your introduction there, Banshee, a massive thank you for everything you do. You've got so many roles, so many hats that you're wearing, but ultimately you're helping diabetes community. You're shaping the future of diabetes care, not only in India but across the world in your sort of role. So honestly, thank you so much. Can I ask, what do you love about your job the most, would you say, and what's the most challenging thing like working in diabetes?
so most challenging is to educate a person with type 1 diabetes, particularly the caregiver. So one is when child is very, very young, below the age of 5 or 6. To educate the child is really a very challenging
Mm.
job. And then to educate the first time newly detected diabetes person with a young child, or he is very young, and the caregivers, which is family. And particularly those who are coming to me from a rural background, their education level is again very poor because
Yeah.
they don't know anything about diabetes. That's the most challenging. But I love what? I love if I start treating those type of patient, and after educating, when I see them, they had come with a better control. Now they are very happy with a smiling face, taking their injection properly, checking their sugar 4, 5 times, 6 times. I
Yeah.
could teach them about the educating, carb counting, and all those things. So that gives you the, you become most happy when you have really changed the life of someone.
Yeah, and that's what it's about, isn't it? I was diagnosed at 17 and I'm based in the UK, but things obviously are different. I
Only
understand that.
the teenagers who are diagnosed at the age of 17 or 15 or 12 above,
Yeah.
it is much easier. But you think of a child who is 3 year old, and then to
Yeah.
educate him about the diet, and the mother,
Absolutely.
father, and they are coming with a rural background. They don't know anything about the diabetes. And that's why
Absolutely.
very
Yeah.
challenging.
It's really challenging at such a young age. My son, he's 5 now, my daughter 2, and I can't imagine what it would be like for us to be managing their diabetes at that age is really really tough. So yeah, thank you for really sharing that. What I do like what you said is that it might be challenging at first when someone's diagnosed and they have to come in and they have to learn about all diabetes and all the new treatments and things they have to do. But like you say, is step by step with you supporting them, they maybe get that smile where they feel much happier and manage their diabetes. Can I ask, in India, what sort of treatments for type 1 diabetes now is what technology, what is available for someone who is diagnosed with type 1 diabetes? Like, how do you support them? What do they use?
So we are lucky that we have everything available in India. That's number one. But access to all these things is not there for everyone. Number one, that public hospital, the
Yeah.
insulin is available, but it is regular insulin and glargine. But in private setup, they can get the best, even like a degludec and the fastest acting aspart also via that's available. We don't have the continuous glucose monitoring and self monitoring of blood glucose or glucose meter in the strips, which is given free of charge from public hospital, but that is available in private setup. They can buy and they can do it.
Mm.
We are happy that some of the international organizations, some of the national organizations are helping our children with diabetes by providing them glucose meter, strips, and some of the best insulin like CDIC project, LFSC, our own Diabetes India, and Diabetes Technology Network, Type 1 Diabetes Network, which we have created with the help of RSSDI. We are providing some of our children, even everything free. Many of the doctors in India, they are also very committed, and they are in private setup, including myself. We just give this service completely free of charge. So it's not like they have to pay. But still, they have to pay for their transport, for their travel to come to this tertiary center, and some of them are so
Sure.
poor they can't afford that also. We have pump, we have AID also, automated
Mhm.
insulin delivery, but
Mhm.
we don't have patch pump. It is costly in compared to, because the income wise, some of the patients are very affording, they can afford. So we
Mhm.
have few patients who are on even AID. But the problem is again, AID itself, educating for AID to a type 1 diabetic patients, all endocrinologists and all pediatric endocrinologists, they themselves are not very convinced to write to the patient. They have to educate the patient because a patient will not accept the treatment, which is costly one, which
Yeah.
is like AID system, and which they have to pay from their pocket. And every month they will have to pay for almost 20,000 rupees, which is almost 200 pounds in a
Wow.
month. So that's
Yeah.
a costly one for them also.
Yeah.
So for that, we have to educate, we have to explain them how it is cost effective for you, because it gives you good
Yeah.
quality of life, it will increase your longevity, chances of complication will be decreased, and
Yeah.
that requires a lot of education. We don't have
Absolutely.
dedicated type 1 educator in public hospital, but some of
Mhm.
centers like us, we have a tertiary care center. So I can afford to have a social worker, we can afford to have a type 1 educator, we have a dedicated pump educator, one of my type 1 who is on pump. We are made her as a type 1 pump educator, so she can talk, she can teach. So there's a lot of, our work is taken care by her. We have
Yeah.
dedicated nutritionist and online support also, but that support system is not available in public hospital. So the India also, we have a lot of disparity in terms of exactly where you are born and where you are going. So that will decide your treatment.
Mm.
Suppose you may be rich enough, but you are not reaching out to the doctor who is expert or who is really ready to give you the best therapy. You think that you have reached out to a doctor who is endocrinologist or a pediatric endocrinologist, but actually he is not giving you the treatment which is at
Yeah.
present is a standard of care in the world. Or if you are poor and reaching out to a public hospital where even they are not explaining you for the self monitoring of blood glucose. So that's a lot of disparities there, and for that we are working in last 15 years to educate, first educating the doctors, because
Yeah.
if we can do the capacity building, if we can educate the doctors across the country, then the care for type 1 diabetes will improve.
Yeah. Absolutely. And I think I remember listening to your talk when I saw you at ISPAD, and you know what I mean. I think no matter where you are born in this world, you know what I mean, people should have access to the right things. It doesn't matter where you are. I'm going to show this slide because is what I really found really interesting from your
So
your
I had
your
shown here in this slide, particularly the disparity that some of the patients who are taking from the insulin syringe, and they don't have the place where they can store even the insulin, even if they get from the hospital some extra amount of insulin for the next 2 months or 3 months or 6 months supply. And India is a tropical country where the temperature is very high. They don't know where to store it, and we just explain them how, at a cold place in their home, they have to store it. And other
Mhm.
side, we have also the patients who can afford continuous glucose monitoring and insulin pump and AID system also. So there's a lot of disparity in India itself. And as now I am the
Mhm.
chair for Southeast Asia, which includes countries like Bangladesh, Pakistan, Sri Lanka, Malaysia, Indonesia, Myanmar. So some of the places there's no availability of technology also. So that's a challenge. Disparity is very high in poor countries or low middle income countries. But some of the patients who are very affording, I always say that at least those who can have, those who can afford, it is duty of our doctors that we educate them, and we
Mm.
educate them for best of the best therapy. At least they can afford. 20-30% of our patients can afford, And I'm sure if we educate them, they buy it also, and they continuously use it, and they are very good. I mean, their control is
Yeah.
extremely as good. We have presented their data also in different meetings too.
So, do you think in India there will be a time where all treatments, all medication, all tech will be available for free, so people have the access that they need? Is that
So
what you're
I
striving
don't
to
think
achieve?
the government will able to do it, because in India, I don't know about this, but you know that very few people are actually giving income tax. So our taxation system is like that. 50% of the people who are poor, they are not earning enough, so government is not asking any amount of tax from them.
Mhm.
Then another 20-30% of the persons who are in some place where they are in a public place, or like a government service, where they have to pay but very minimal amount of income taxes they are paying. So the income tax itself, the government revenue is so low. I don't think the treatment for advanced treatment particularly will government or public hospital will give free to everyone. But
Mm.
yes, the basic care should be there available, and it is available now, and it is increasingly available even at a district level or a taluka level, which is like in the rural level. But
Yeah,
what is not available is education. And
education.
I think what is our duty as a organization, as a person who is working in organization since last 15 years, as a Diabetes India, I think my duty is to educate all those doctors, all those nurses, all those foundation people, all those educators, which we can create them. At least education can be given free to these children, needy children. And if
Yeah,
they will be given education, I'm sure they will get insulin therapy and some of the things which is available in the government hospital free of charge. So combination of this will improve the care for them.
absolutely. And how many people are currently diagnosed with type one in sort of India? What's the sort of numbers, and is it rising as you're finding it, like,
Yeah.
as the years
So
going on?
there is a data that in India, if you see type 1 and type 2, the 6.5% increase in type 1 in compared to type 2, it is 4.8% increase every year. So it is increasing. Autoimmunity is increasing. You know that as your economy is increasing, autoimmunity diseases are also on the increase side. The other is we have IDF data of 2021, which is showing that we get 24,000 below the age of 19 years. It means young adults and young children who are added in the list of 229,000 children which are already there. So we have these many people which are already type 1. We are having highest number of type 1 in the world below the age of 19. And we
Mm.
also add 24,000 in this list every year. Unluckily, we have adult population which is less than 1 million, because many of them are dying early in the course of type 1 diabetes. So
Wow.
they live only up to the age of 30 or 40, or they live with a lot of complication also. So that's a
And
challenge.
what's the cause of them dying then? What's
So
the common?
diabetic nephropathy is the commonest complication. The kidney disease, diabetes kidney disease is the commonest cause for uncontrolled diabetes. So first 10 to 15 years, but later on they develop DKD, which is very common. So that is also one of the reasons that increases again a cost of burden of complication, because that complication itself is so high, and that requires a lot of treatment and therapy, and many of them are not able to survive for them, because we can't give everyone them dialysis or a kidney transplant, or
Yeah,
so many things are there.
really, really sad, isn't it? And is there many people who are going undiagnosed and maybe falling ill or dying because they
So
don't know
that
enough? And
population
is that
is
why education is
that
so
population is
important? So,
decreasing. Tom, that population is decreasing, that someone who's completely undiagnosed and dying, yes,
right.
they may be late diagnosed with a diabetic ketoacidosis. So when they are reaching to the hospital, already they are in diabetic ketoacidosis with pH is decreased so much so, and sometime in a primary healthcare center where a doctor who is not trained enough to treat DK, which requires very advanced treatment and education properly, sometimes they die for that. So you can say undiagnosed or a late diagnosis may be
Yeah.
reason for the patient to die early, but still most of the people are diagnosed. One recently we published a data. I mean from India, not I am not the part of it. It is from a tertiary care hospital from Delhi, in a advanced care hospital. So they were having their patients data from 2003 to 2009, which is almost no 2006 to 2012, which is 6 years data, which they compiled for all type 1 diabetic patients who were coming to their 1800 patients longitudinal data which they had provided, and out of them 11% of them died in this period of time because of complication, not that because they died in decay or infection. So
Yeah.
uncontrolled diabetes led to infections like tuberculosis or pneumonia and some other infection, and that is the reason for them to die. So it is not the long-term complication has killed them; it is the short-term acute complication like hypoglycemia or diabetic ketoacidosis or infection, which is the reason for them to die.
Mm, mm. I guess it comes back around as well, like you say, education is so important and is raising awareness so people are aware of diabetes and the signs and symptoms, and people can get to be seen as quickly as possible if they
So
if they
for that,
start.
Diabetes India, we are having a national campaign to detect them early. So
Bro.
we have created a flyer which is just
Yeah,
talking about the what could be the early sign, and that we are distributing in the schools
that's good.
and young children, and just writing on our website and asking the people that how they can detect. So it's a very simple, if a child is losing the weight or the parents are asked to understand that child is now bedwetting or doing urination in night time, asking for more time of frequency of urination increase, that's the immediate time they should reach to the doctor urgently. I mean,
Yes,
anytime when they find there is a frequency of urination increase, they started increasing water intake, there is a weight loss, or they find that child is asking for more food and all these things, they should reach out to the doctor as early as possible with the
definitely. Yeah. While we're on topic of education, I just want to bring up a good friend of ours, which I know you know really well, Jazz Steffi from the Diabetes Foundation. And I think people like Jazz and the Diabetes Foundation, you know what I mean, the amazing work that they're doing to educate and care for young people is phenomenal, isn't it? It's great work, and it's just fantastic that they're supporting these people who need that help, right?
Yes. So there are foundations across the country. These all foundation, this diabetes and judges from my city, and they are doing wonderful work. Their work is awesome. But in different cities also, the patients, either their parents or they themselves have made the foundation. And this is more than 100 foundations are
Mhm.
working across the country. Uh, the number of persons one foundation may have between 100 type 1 diabetic to maybe up to 500 and 1000. One of the big foundation is based at Rajkot, which is near to our city of Ahmedabad, 200 kilometers. They have 1500 type 1, and they are managing them very regularly and very meticulously. They are educating them, treating, giving them therapy, everything. And they have hired the doctor, pediatric endocrine and everything. So people
Mm.
are working for it, and with these foundation help, more than 20-30,000 children actually in India are getting good education about the diabetes. They are able to control their sugar, they are getting glucose meter strips, insulin either through public hospital. They are
Mhm.
also in touch with the doctors on a regular basis. They get 24 by 7 emergency contact number also, so that's also helpful for them. They don't get diabetic ketoacidosis, they don't get admitted for hypoglycemia, so they lot of benefits are there.
Yeah.
And these foundations like diabetes, with the help of their educators, they give also online services. So they are actually working along with the doctors, because many of the doctors are also working in the same field. They also have their own
Mm.
foundation, and like Udan, which is from central India, like my Care. So many of these foundations are really working good, and they are helping children with type 1 diabetes, their
Yeah.
parents, their caregivers. And we are also empowering these children once they are above the age of 19. We ask them if they want to become the educator, if they
Amazing.
want to become dedicated type 1 educator.
Are you finding then part of the programs to help educate people, and hopefully that helps people's quality of life and management of diabetes? Is that hopefully helping with some of them figures you said before about people who might die younger living with diabetes in India? Do you think if you've got good education and hopefully good treatments, that will hopefully give you that quality of life and give you as much as a life as possible to live the best possible life.
So education can definitely improve the care for it, and that requires a lot of awareness. So we have less awareness, and now it is improving because of the social media is really helping us a lot. All those who are type 1 now without having any taboo, they openly come and say that, I developed, like you just told that I developed type 1 with the age of 17. So someone who will say that, see, I am on CGM, I am on pump, I am on this, they are on social media, they go and show everywhere. So this increasing awareness is really helping.
Yeah.
The children with type 1 diabetes who are uncontrolled, they feel they are not good for neither education nor they can do anything else. They remain in depression. So this diabetes distress can be reduced with a lot of education, and by peer support, it really helps them. So when we invite them, that's what we do every Saturday. We all type 1 who are, this week, any newly detected diabetic patients with the caregiver, with the family member, and plus one or two older person with type 1 diabetes. We invite them on every Saturday in our clinic. There's a room and we educate them. We just try to explain them what are the things. And it take almost half a day to one full day. My team is completely educating them for nutrition, for injection, for monitoring, for carb counting, for correction dose, for sick days rule, and all other things we try to do it. And we try to give them support system also. From each and every district, we have some type 1 diabetes, and they are now having diabetes since last 10 years, 15 years. And they themselves are more than 18, 19, 20, 21. So we ask them, do you want to do some service, at least 5 patients under your care? They can contact you anytime. And some of them, they agree. So one or two patients, their family member, their caregiver, or their patients themselves, they can directly contact these people, and they also remain in touch with them if they have any issue. Because what happens, sometimes they don't come out and they tell any problem to doctor directly, but when we try to connect them with some person who is already type 1,
They'll
then
talk.
so they personal issues, they can talk to them,
Yeah.
and they may feel shy to talk to the doctor that, I have this challenge. But then that helps us a lot because we get that feedback from them, and accordingly we would like to treat this patient. The other challenge which we are seeing with the school going, because in schools still there is a challenge, because patient or person with type 1 diabetes, the child with type 1 diabetes does not want to show other children that I am type 1.
Yes.
So, and he or she is not ready to take injection in school. He or
Yeah.
she is ready to check the sugar inside the school. His sugar getting a lot of hypo and hyperglycemia inside the school. He does not want to tell that my teacher should know that I am type 1. Even we are ready to talk to their school authorities or the
Yeah.
principal, the teacher, but sometimes the children and the family is not interested to talk to them.
Yeah.
So that's a challenge, and that's a really a big challenging issue. But we are slowly coming out of it.
So because I remember when I was diagnosed at 17, like I said before, is I remember being at school and I didn't want to check my levels or inject, or I'd go to the toilet to do it, which you shouldn't have to do, things like that. And I'd run my levels higher because I'd be afraid to do it in front of my peers. I just wanted to be normal, right? And I was, I guess, worried about what people would say. Would they blame me? Would they say stuff that they just don't understand diabetes? And that's where I guess stigmas come into it, and people say certain things. Is that the sort of reason you think people in your schools are maybe not talking about it or not doing certain things? Do you think it comes down to the worrying of what people will say or do, or is it to do with stigmas and things like that, misconceptions?
That, once you tell everyone that you are type 1, it is only that distress or that depression, maybe for a 1 day or 2 day or 3 days or 5 days, but then lifelong you will be out of that distress permanently. But if you will not tell everyone, your family should not know, your distant family member should not know, your friend should not know, your school teacher should not know, that keeps them with a lot of distress. They always have that, nobody should know, nobody should know. That type of feeling is very distressful. I always explain, it's better to tell everyone that you are type 1. There is nothing wrong. You have not done anything wrong. God had given, I mean, for some reasons, it is autoimmunity, which is the reason for you to have a type 1 diabetes. Don't worry.
Yeah.
Now, therapy is such a good. With AID, when we explain that, like, it's like a cure, you will be always good. You will always have a good level of sugar, nothing to worry. Only few things you have to avoid in your diet, which otherwise also we tell for obese person also, for overweight, for many things also. So, I mean, don't worry for that. But even there is a lot of issue, that still it is very difficult.
Absolutely. Yeah, I totally get that. I guess it comes back to full circle as well, isn't it? Of educating schools as best as you can, raising awareness, getting them to support the young people, and I guess you're trying to do that to try and support them young people in schools by training staff or letting them know. I guess it's important to do that and talk to schools. So is it important for schools then to be involved and have that education so that
School program also, that International Diabetic Federation, with them we have decided we are doing kids program. There's knowing diabetes in school. That's what the program itself is there.
yeah
And we send regularly the doctors to educate the people, not only for type 1 diabetes, but for pediatric obesity also, because now we are getting pediatric type 2 diabetes too in India. That's again a challenge with the young adults too. So we try to educate them, and for healthy diet too, for someone to remain healthy. That is what our plan is, and we educate the schools and all those things. But still, it's very difficult because some of the schools say that we have only 2 child with type 1 or 1, and many of them are not knowing. So, full school with 2,000 school children, we ask everyone, if anyone have type 1, please inform your teacher. Some of the school teachers and principals, and they are also too much worried when we explain them for hypoglycemia and all those stuff. So how you explain that is also very important, because if doctors is going and explaining in a way which can lead to sort of a teacher may become very that this can be a very dangerous situation, like when we are explaining for epilepsy, that child can have a fits in the school also. So there is a possibility neurologist, pediatric neurologist goes in the school and they teaches that how you have to handle this type of situation. So hypoglycemia also we try to explain, but not in that it's a very serious condition, but you should allow the child to have a direct sugar or candy, or to check allow the sugar to be checked by the child. They should also understand when someone is perspiring or some symptoms. They should understand if someone is going again and again in the washroom, there is a possibility that his sugar is not under control. He should be allowed to check the sugar before their major meals. They should be allowed to have a sugar check, and they can be allowed to take the insulin injection. So there should be some privacy, some dedicated place, a room where they can take the injection also.
absolutely
And so the schools have started doing it. I've been telling you, once we explain them, they do it. They
the
have
support
dedicated nursing room also. They support.
Yeah, no, it's great. Thank you. So I remember seeing this at your presentation. Can you talk us through this image that I'm showing on the screen to the community?
So
And
this is, I love this slide actually, to be very frank.
yeah,
We as a doctor, we always see that we are giving our best therapy to everyone. And we feel that we are equally doing good for everyone. But sometimes that equality is not sufficient for someone who is receiving. Because giving equality may be good, but it is not sufficient for many of our people with type 1 diabetes. Like suppose someone who is coming with a very rural background, he needs or she needs more education. Suppose someone who is coming with a very young child, that requires a lot of education to the caregiver. So your equal approach of 15-minute consultation may be completely insufficient for someone who needs a 2-hour education, or someone who needs for a pump or a education for continuous glucose monitoring. You may require more time. So in terms of equality and equity, I think you have to decide your time depending on what type of person to whom you want to give. That's one. The second, regarding the access and suppose you are seeing someone who is coming from 300 kilometers, you just want to give him a therapy for 15 days. That is, that it is not going to be sufficient. He can't afford to come back to you within 15 days or within 1 month. You have to give a sufficient amount of supply to that child, and at the same time you have to create some sort of a online educating system for next 3 months, because that is what is required for that.
Yeah.
So your equality approach will not be right approach of treating type 1 diabetes. And that's what I tried to show in this particular picture, that it is not like that giving everyone shoe. You have to give a shoe which is fit in his fit. That is important. So just giving shoe to everyone is not sufficient. It has to be uh, very, very size specific. Then again,
Yeah.
according to his comfort, also you have to give. So everyone will not be requiring a leather shoe. Some of them will need a sport shoes also. That's what a difference between a equality and equity approach.
I think you're absolutely right, isn't it? That each person's care is so individual, that they have so many different needs and aspects. And like you say, when you come for your appointment, 10, 15 minutes or whatever, you want to make the most of that appointment and go after that appointment feeling that went well, and you've got your next steps to go forward. But yeah, I really like this image, and I love how you describe it there. In terms of globally, then, why are there disparities in diabetes care and inequalities? Why is this happening? And is there anything that what needs to be done to try and reduce this? And we, of course, we want to be in the world that we all get the right care, the right access, the right education, the peer support, psychology support, like you've mentioned. Like, why
So
is
not
this
only the
disparities?
diabetes therapy have disparity in everything. So now disparity in education also.
Yeah.
Like if someone who is born in a developed country will have a different access for the education with someone who is born in a country where that education system is not available, he will not able to have that access also. So there is a lot of disparity in that education also. I mean, a child should have a right of education, but you know that there is a lot of disparity. If someone is in developed country, developing countries, underdeveloped country, so there are a lot of disparity in every. Suppose someone who is born in a rich family, he can afford to have the best T-shirt and best pant
Mm,
and best T-shirt. So there is a disparity between
mm,
a person who is born in a family who can afford and who can get the best therapy. The same way he can afford to have a private car, and someone cannot afford even a public transport also, because he can't afford for few pound to go even in a train or a bus also. So disparity in every part of the life.
way.
It's not
Yeah.
that it is only for the insulin therapy or this. But yes, when it goes to insulin, at least that's a minimal care. That disparity should not be there around the world. So that is what the idea, that no child should die because of
Yeah.
getting insulin. So at least some basic care should be available
For everyone.
everywhere. I'm not
Yeah.
talking of only India, whether it's in Africa or some country where it is not available, where also it should be available. So that is what the basic. So we have to go from the basic to the advanced, that depending on multiple things. Now, to get the advanced therapy, first you need to have a good doctor also, because that's most important thing. He has to decide the therapy and he has to give the best therapy. He should have that knowledge of giving that, first of all. Then he should have a system of giving it. So I should have a, if I know it, but I should have availability of these injections or the pain or the connected pain or CGM and the pump, which should be available in my country so I can prescribe.
Yeah.
And then I have to have a system who can educate my patients. So even my patient who can afford all these things, if I don't have that system, I will not able to give him best therapy. So I know that I've been trained in maybe somewhere else, and I know that best therapy what should be a type 1 should have. But still, if I don't have access, suppose he is in Cambodia or a country where pump is not available, even he knows that pump is
Mm.
best therapy, how he will able to give that, deliver that patient a pump therapy. So there are a lot of reasons for disparity, but I believe that at least basic should be given everywhere, anywhere in the world. The basic care should be available.
I think you're absolutely right. You know, that basic level of care of the insulin and a way of checking and monitoring your levels in whatever capacity that is, whether it's finger pricking or CGMs or whatever, that's the basics, isn't it? Of
And
course, we
education.
want.
And I tell you, this is all thanks to like you also who is doing diabetes chat, because this all will go on social media. So through this, we are reaching out to anywhere in the world.
Yeah.
Suppose today I'm talking here in Ahmedabad and people are listening me tomorrow maybe in Africa. So this will increase awareness in every part of the world. That's very important. So we all of us are through with the help of this online and this platform, we are reaching out to everywhere in the world. And definitely in coming few years, we will able to give basic care around the world. But definitely the advanced care, there will be disparity. I don't think there will not be any disparity. It will
Yeah.
be still there, because the time will come that like in Europe also, Italy have decided for all the children to get for screening, and tomorrow Italy may be the first country to give the immunotherapy for prevention of diabetes. But that is not at present. UK government have not decided. So I mean, UK still we will have the children who will develop type 1. They will still be good people who will be developing diabetic ketoacidosis, because you are not preventing them with the immunotherapy. The same way, a beta cell replacement may come after 5 years, but the supply for that will be very less. So maybe
Mhm.
the countries where it will be available, maybe very few, and then the things will improve and change. So disparity will be always there.
Yeah, yeah. No, thank you for saying that, and I've really taken that in. So thank you so much. Like you say, it's happening not only in diabetes, it happens in everyday life, but and I liked your examples there, but also then bringing it back to diabetes. It's very sad there's disparities, and like you say, people deserve that basic level of care, and anything else is absolute bonus, and hopefully one day everyone can get what everyone deserves. So, in terms of sort of concluding, really, is what are your sort of hopes and aspirations for diabetes care and management, and that could be in India, that could be globally, in the roles that you're doing. What are sort of what are your thoughts and aspirations for the future, and to just to improve diabetes care?
Mission is to give the basic care to everyone around the world, and that's what mission. But vision is to have the best therapy like AID to every child. Vision is that to have a immunotherapy for everyone who will be diagnosed early in the course and they can be given a therapy for prevention of type 1 diabetes. Vision is for like diabetes prevention vision or diabetes free India. That's what the vision can be there. Like we don't have even type 2 diabetes also, because if you
Mm,
educate in a young age that how you can prevent yourself to becoming diabetes for type 2, I'm talking that lifestyle modification will help them to delay the diabetes. So for primary prevention for type 2, that can be a vision is like to have a immunotherapy for prevention of type 1 diabetes, or
yeah,
someone who have developed type 1 diabetes, they can be on the best therapy like AID, so they will not need hospitalization neither for hypo nor for decay, not for any complication. So they all can be, you can understand that that is what I think maybe 2050, when we will be becoming developed country, maybe after 20 years or 25 years, for India or around the world, at least minimal basic care should be available around the world for every child.
yeah,
Like we are giving a right to education, each and every child who should also have a basic primary education everywhere, whether someone
yeah,
is born in
absolutely.
any
Do
part of
you,
the world.
do
They
you
will
think
be.
it will get harder though as time goes on with the increase of people getting diagnosed with type 1, type 2? Do you think it will get harder? So if there's already disparities and people are struggling to get access to certain things, if the numbers of people are diagnosed globally, does things get harder? I guess that's a given.
So, number of children increasing in the world, but at the same time, the country's possibility of giving them all this therapy will be still difficult. So, because there are few companies who are now recently, that one of the big company in the world who had stopped making the human insulin in a cartridge form. So, these some of the challenges, because they are running actually industry, they are running a pharmaceutical industry who is made for profit, so
Hmm.
they can't afford. So unless it is, some of the initiative have to be taken by the government to create these of the basic manufacturing facility or creating some sort of things for these basic care. Like in India, the government of India, the Prime Minister have started across the country at a very low cost. The medicine is available in a private setup also. So a person who is not affording, even for every disease, you will get that insulin less than 3 pounds. The glargine is available in that vial is available. So I mean, that sort of a support system will definitely help the people to get the basic care around the world.
Great, thank you. And just to finish then, Banshi, is obviously thank you so much for coming on. Thank you for all the fantastic work that you and many people are doing in the diabetes space. We honestly really appreciate it. But what would your sort of final message be to anyone that is watching, listening now, or watching back on the podcast? Like, what would your final message be if there's anything we haven't covered today, or what would you want people to take away from this tonight?
So the final message I will say that, for everyone, diabetes is a global challenge. It's a global issue. And that's the reason the International Diabetes Federation had put their blue logo. It is unite for everyone. So someone who feels that I'm not diabetes, why I should be more interested to know about diabetes, because he's also the part of that ecosystem.
Yeah.
It requires education and awareness at every level, whether you are in a politics, whether you are a minister, whether you are a engineer, whether you are an industry person, or whether you are a poor person, or you are a farmer. So everyone has to understand, because this is a global problem. We are having a lot of people with type 2 diabetes. At the same time, we have people with type 1 diabetes. We also have hyperglycemia in pregnancy, which is the gestational diabetes. We develop secondary diabetes. So many challenges are keep on coming, and we have a lot of people with type 1 diabetes. So I think increasing awareness is a key for getting more education. If I am more aware about the disease, I will seek for more education. I will go either on a social media, on a Google or somewhere. I will try to understand and learn about that disease more. And if I will know about that more, I will definitely go and get the best treatment also. So I'm sure in future, people will understand the disease better, and they will able to get the best treatment which is available to them.
Yeah, I think that's a fantastic message to end. We've seen over the last over 100 years or so since insulin was obviously started being produced and made. So we've seen the roadmap already this past 100 years, and let's hope for a better, a brighter, a more healthier years ahead. And I think we're in a good place when we have good people like yourselves who are supporting people like us. So from everyone at Diabetes Chat tonight, thank you so much, Dr. Banshi Saboo, for coming on.
Good night. Bye-bye. Bye, Tom. Thank you.
Thank you.